Breathing. The intake of oxygen and exhalation of carbon dioxide is something that most people take for granted until something happens. In today's world, threats abound in the very air we breathe. According to the World Health Organization, in 2009, an estimated 210 million people suffered from pulmonary diseases worldwide. Total deaths from pulmonary diseases are projected to increase by more than 30% in the next 10 years, unless urgent action is taken to reduce basic risk factors. The latest numbers issued by the Department of Health show that pulmonary diseases such as pneumonia, tuberculosis, and chronic lower respiratory diseases are among the top 10 leading causes of morbidity in the Philippines in 2009. Lung cancer is still the leading cause of cancer mortality in the country.
Basically, since the Philippines is a third world country, infection is still the #1 cause of lung diseases in the Philippines. No? But lifestyle diseases is also rising. No? So when it comes to infection, we talk about tuberculosis, we talk about pneumonia, we talk about bronchitis, and upper respiratory tract infection. Because of globalization, lifestyle diseases is also on the rise. No? What are the lifestyle diseases of pulmonary medicine? These are the lifestyle diseases caused by pollution, because of industrialization, and smoking. And the diseases that would fall under this would be chronic obstructive pulmonary disease, chronic bronchitis and emphysema, and lung cancer because of smoking, and the rise of bronchial asthma because of pollution. So basically, these are the lung diseases in the Philippines. Compliance is always a problem when it comes to treating pulmonary diseases. Let's talk about tuberculosis. When it comes to tuberculosis, maintaining the medications for 6 months is always a problem for third world countries because of economic difficulties of patients. No? When it comes to other diseases, compliance is still an issue. We always tell our patients to stop smoking for lifestyle diseases like chronic obstructive pulmonary disease, cancer, but it's always difficult for smokers to stop.
The St. Luke's Institute of Pulmonary Medicine is equipped with state-of-the-art facilities capable of performing the most advanced and comprehensive diagnostic examination.
Having the best equipment is always an advantage. Especially in pulmonary medicine, we rely a lot on imaging. When it comes to imaging, we talk about chest x-rays, CT scans, PET scans for cancer, the MRI. So we need good imaging tools or diagnostic tools to help us to diagnose our patients. No? When it comes to therapeutic, it has been proven that simple medical management is not enough for some pulmonary diseases like COPD. So pulmonary rehab is an integral part already in the treatment of COPD. So we need, in pulmonary rehab, we need all the proper equipment, proper training to address our COPD patients. No? There are some diagnostic tools like the cardiopulmonary exercise test, which help us in diagnosing causes of shortness of breath or difficulty breathing. The best diagnostic tools, the best equipment is always an advantage in any medical problem or any medical field for that matter. And pulmonary medicine is not exempt to that.
Equipment like this enables its highly trained staff to diagnose and treat a wide range of lung ailments, from the common cough to the most complicated pulmonary disorders.
In IPM, of course, we have our body plethysmograph, which measures lung volumes of the patients to know if the patient has obstructive airway disease, and to know the diffusing capacity of the lungs of the patient. No? So this is a tool that is already complete when it comes to knowing the pulmonary function of the patient. No? Only a few hospitals have the advantage of having a body plethysmograph, no, to measure all these things. We have the cardiopulmonary exercise test, which again addresses causes of shortness of breath. No? It addresses shortness of breath caused by the cardiac system, by cardio, shortness of breath caused by the lungs, and shortness of breath caused by being deconditioned. No? So what is good about this test is it addresses all possibilities of or causes of shortness of breath and difficulty breathing. It is a stress test in itself to know if you have a heart problem, you have ischemic heart disease, and it also measures pulmonary functions as well, and muscle deconditioning. So I feel when it comes to treating or diagnosing patients, it's already a complete tool when we talk about shortness of breath. Then we have the ventilators, of course, for our critical care. We have the best top of the line ventilators to treat our critical care patients. We have our bronchoscope to assess our patients when it comes to wanting to know the endobronchial lesions, wanting to get samples and specimen samples in the lung when it comes to complicated pneumonia, tuberculosis, and for biopsy of endobronchial masses. No? Then we have the indirect calorimetry, which measures the proper total caloric requirement of the patient, especially for patients in the critical care, patients with COPD, wherein nutrition is very important. And of course, we have our usual ABG machines. We have our usual nebulizing kits.
The continuous education and training of doctors at the Institute enables them to provide the best possible treatment offered in the country and in the world.
It is common practice in the field of medicine to have continuing medical education. And doctors in the Institute of Pulmonary Medicine regularly go to international conventions to update themselves when it comes to pulmonary medicine. Of course, we also have our local conventions in here, wherein again we update ourselves in the latest in pulmonary medicine. A lot of our consultants trained abroad for subspecialties in pulmonary medicine, like pulmonary rehab, for invasive pulmonary medicine, dealing with bronchoscopy. Some are trained when it comes to sleep studies or sleep obstructive sleep apnea and intensive care, pulmonary intensive care. So basically, a lot of our consultants are well equipped when it comes to pulmonary medicine, when it comes to knowledge, because of this continuing medical education and their training they had abroad and locally. Since IPM, or the Institute of Pulmonary Medicine, is a training institution, especially in QC. We do have our pulmonary fellows, and they do conduct or they do a lot of research when it comes to pulmonary medicine. It is integral in their training, and it is actually a requirement in their training. We do have regular research outputs from our fellows, and they are assisted or they're co-authored by our pulmonary consultants as well. Of course, research is very important when it comes to management or in helping manage our patients. The outcomes of this, once it is a well-designed study or well-designed research, we could apply clinically. As I mentioned, we had a research on outcome of weaning or outcome of protocol-driven weaning, And it showed that as long as we follow a certain protocol, then the outcome of patients in respiratory failure patients hooked to a ventilator is better. No? So examples like this help us in our practice. For some, for diagnostic researchers, therapeutic researchers, then we are guided accordingly. So research is, again, a very integral part when it comes to patient management.
At the St. Luke's Institute of Pulmonary Medicine, the medical staff goes beyond mere treatment and diagnosis of disease. With psychosocial support and patient education, the Institute ultimately helps improve patients' quality of life.
As I mentioned a while ago, compliance is very important when it comes to treatment of pulmonary medicine. Psychosocial support and patient education would address this. A perfect example of that would be our pulmonary rehab program. In pulmonary rehab program, we are dealing with COPD patients who have been addicted to smoking for several years. And the reason they had COPD is because of their smoking history. Patient education on smoking cessation is very important when it comes to treating these kinds of patients. Also important because they need all the support, they need all the encouragement from their family members, from their friends, also from their doctors to achieve the goal of smoking cessation. That is only one example. In cancer patients, we need also a lot of psychosocial support, bringing in all the relatives, all the team and the doctors and the fellows in dealing with patients like this, like cancer patients, COPD patients. We make sure that we treat our patients well. We give the utmost patient care in all our patients. We train our RTs and doctors when it comes to patient safety. So all this are all compatible to the thrust of the hospital, which is patients first and good patient care, patient safety.
The St. Luke's Institute of Pulmonary Medicine. Experience, expertise, cutting-edge technology. These allow us to breathe new life into every patient.
Go hard, go! Go, 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 go! Release all the air, release all the air out. Very good, very good, very good. And ready, ready. Very nice.
Ultimately, it is expertise.